Hi, my name is Irtaza Asar. Welcome back to the Brain Course. And for this talk, we're going to be talking about syncope. But as an introduction for myself, I am one of the core faculty members as well as the clerkship director at the AHN St. Vincent Emergency Medicine Residency Program. I'm also the host of a medical education podcast called The Learning Curve. I'm going to give you a lot of tips and tricks to managing syncope in your emergency department. This is such a challenging topic, but I hope I can make it a little bit easier to set you up and your patients up for success in the future. So let's get started with the case. We have a 68-year-old man who collapses suddenly while he's standing during a wedding ceremony. And I promise you ahead of time that he is not protesting the wedding. That's not the end-all result of this. Witnesses say that he was standing for several minutes, and just before falling, he became pale. He was unresponsive for about 10 seconds. There was no postictal confusion or shaking. EMS reported a brief systolic blood pressure of 85/60, but it normalized en route. He denies any tongue biting or incontinence, and on neuroexam, he's completely normal, there's no cranial nerve deficits, and there's no murmur on exam. His EKG also does not show any signs of any ischemic changes. The questions that I want to ask you that I hope that I can answer for you during this lecture are as follows. Number one, what are the key features in this case that suggest syncope over seizure? What physical exam findings could help you distinguish between these entities? What are the red flag features in this case? What initial workup is appropriate for this patient in the emergency department? And what discharge instructions and return precautions would you give for this patient? So to set the stage for this conversation, let's define the word syncope. Syncope, by definition, is a transient loss of consciousness that occurs because of reduced cerebral perfusion. And the idea here is that syncope generally tends to be rapid in onset, and it tends to have a brief duration, and our patients will spontaneously recover very quickly. Why is this important? The reason why is that this is actually a very common chief complaint in the emergency department. Around 3 to 5% of patients that present to the ED are going to be presenting with syncope. And there's a broad list of life-threatening causes that we have to really rule out. From the heart standpoint, we're thinking about arrhythmia, we're thinking about ACS. From a lung standpoint, we're thinking about PE. From a GI hemorrhage standpoint, we're thinking about GI bleeding, we're thinking about ruptured aneurysms. And from the brain standpoint, we definitely want to consider strokes and ICHs on our differential. Our priority is we want to try to narrow the differentials down as fast as possible so that we can see if this is a benign cause of syncope or if this is a life-threatening cause of syncope. We want to identify potential risks. Does the patient have any abnormal vitals? Did they fall and suffer a traumatic injury from their syncopal event? Are there any underlying cardiac risk factors that we have to be cognizant of? And what about any neurological disorders that could have led our patients to syncopize? The most common reason, which we'll dive into first, for why patients have syncope is generally neurogenic syncope, or otherwise known as vasovagal syncope. The idea here is that our patients have a transient loss of consciousness, and this reflex arc leads to reduced cerebral perfusion. How this happens is you specifically have an inappropriate or exaggerated autonomic response, which eventually leads to a drop in blood pressure and heart rate. Now, when we talk about this reflex arc, it all starts with a trigger. That trigger leads to vasodilation and bradycardia. The end result is decreased cerebral perfusion pressure, and then eventually our patients syncopize. When we talk about triggers, these are where your history is very important and you want to ask about that. For some patients, it can be an emotional response to something, specifically getting bad news or having a jolt of pain. And one of the more common reasons is the sight of their own blood, especially when they're getting their blood work drawn. And you'll see this happen pretty frequently in the emergency department as these patients will have a short episode of syncope. Like in our case at the start of this lecture, prolonged standing can also be a trigger as well for neurogenic syncope. For some patients, it can be carotid sinus hypersensitivity. And the idea here is they have an exaggerated response to carotid sinus stimulation. That can be turning their head one way all of a sudden, or a tight collar around their neck. And the idea here is that this will lead to abrupt bradycardia and hypotension. There's also situational syncope to be aware of as well, and that can happen under the context of coughing syncope, where patients can have severe repeated bouts of coughing, then get lightheaded and then pass out. There's also micturition syncope, which after voiding they can get lightheaded and then pass out. And then there's also defecation syncope, where they have a large bowel movement and then they get lightheaded and then pass out. There's also swallow syncope, which is triggered by esophageal stimulation. And then there's also valsalva, where patients are either bearing down or trying to exhale against a closed glottis. And the end result of that is decreased venous return and then eventually transient changes in heart rate and blood pressure. Now, this physiological cascade ultimately starts with our afferent receptors. We've got our baroreceptors and we've got our mechanoreceptors. These receptors then transmit signals to our medulla oblongata. And then the medulla oblongata is going to orchestrate a sympathetic and parasympathetic response. The end result is two things. On one side, we get reduced sympathetic tone, which actually leads to a drop in our vascular resistance, causing lower blood pressure. And then we have excessive parasympathetic stimulation, which causes vagal nerve stimulation, causing bradycardia and decreased cardiac output. The end result is hypotension, bradycardia, and your patient's syncopizing. These patients can recover rapidly if they're placed supine. One of the other tips that I've employed in my emergency department is I also, when I lay them flat, I raise their legs up because that can act as about a 200 to 250 cc bolus for them and try to help the return from the legs so that we can get their blood pressure up very quickly. There are some other considerations that we have to have because, again, neurogenic syncope is not the only cause as to why these patients can pass out. We want to consider cardiac syncope on our differentials as well. And that differential can include things like ventricular tachycardia, high-grade AV block, hypertrophic obstructive cardiomyopathy, and valvular disease. We also want to be considerate of orthostatic hypotension in our elderly patients, and that can be made worse by specific medications that they're on and also dehydration. And I also tell patients that, about 30% of them, we're just not going to figure out what the exact cause is. Some patients may get misdiagnosed or underinvestigated, but 30% of them, you might not even be able to find a cause in your emergency department. Now, one of the more common questions that I frequently get from my learners is, hey, what about somebody that almost passes out versus somebody that does pass out? Do we have to treat them differently? For me, the answer is no. And the reason why is that there's been multiple studies that have looked at this. One of the ones that I frequently reference is the Bastani study that was published in the Annals of Emergency Medicine in 2018. And this actually looked at 30-day serious adverse clinical outcomes for elderly patients that were presenting to the emergency department with either syncope and near syncope. And when they looked at these patients that were older than the age of 60, what they found is that they had about an 18% risk of some kind of adverse outcome happening in the next 30 days. So for me, there's really no statistical significant difference. And when we talk about adverse outcomes, this meant either CPR, massive pulmonary embolism, severe intracranial hemorrhage, getting some other invasive intervention. So really, the outcomes are the same. And what I tell my learners is, hey, if somebody tells me that they almost passed out versus they did pass out, especially if they're above the age of 60, I treat it the same way, and their workup is the same. Now, one of the things that we really want to be cognizant of is differentiating syncope from seizure and psychogenic non-epileptic spells. But why do we have to do that? Specifically, our management strategy is going to be different for each of these conditions. And we also want to avoid missing any lethal arrhythmia or failing to diagnose epilepsy. But how do we do that? And really, this is going to be predicated on history, exam, and some red flag signs that we are going to talk about for the next few slides. And I'm going to give you some tips to help you narrow things down on your differentials. So when we talk about syncope, if we're talking about neurogenic or vasovagal syncope, this is going to be precipitated by some kind of trigger that you want to try to ascertain in your history. When we talk about prodromes, we're going to be thinking about things like nausea, blurred vision, sweating, and these patients will generally have rapid recovery once they're laid supine. These patients may also experience brief myoclonic jerking, and I really try to educate my patients about that because sometimes when they think of myoclonic jerking, they're automatically assuming seizure, but that's not really always the case. When we talk about cardiac syncope, it can also have a sudden onset, and cardiac syncope in particular may occur without a prodrome. And if I'm suspecting cardiac syncope, I'm thinking about things like arrhythmia and obstructive lesions. What about seizures? So from a history standpoint, we want to ask about any kind of aura. This can be either visual, this can be auditory, and in some patients, it can even be olfactory. We want to ask about any tonic-clonic activity. Typically, this means rhythmic jerking that lasts less than 1 to 2 minutes. And we want to also ask about some common findings that we frequently see in seizures, things like tongue biting, urinary incontinence, postictal confusion that can last anywhere from minutes to hours. With regards to tongue biting, that's actually one of the exam findings that has the highest specificity for ruling in seizures. And I always make sure that I try to ask about that as well. And you want to ask about any triggers. The most common reason as to why individuals have breakthrough seizures is typically medication noncompliance. Sleep disturbance is another one that can also propagate seizures. When it comes to psychogenic non-epileptic spells, these are typically going to be lasting longer than seizures, and they're going to be linked to some kind of psychological stress that's happening in the patient's life. When we talk about the motor activity that these patients will present with, it'll typically be atypical, and it's going to be more out-of-phase limb movement when we ask them about it. Specifically, it's not going to be that consistent rhythmic motion that we see with regular tonic-clonic activity that's seen in seizures. And the other clue is their vital signs are going to be normal during these episodes. They may not have that prolonged tachycardia or hypertension that patients with acute seizures have. And again, the key thing here is trying to see if they have any physiological changes during these episodes. Now, what about some physical exam findings that can help us distinguish between these three? I want you to remember three key things with syncope. Number one, you're going to get a rapid return of orientation. The loss of consciousness is going to be short. And when we're talking short, it's usually seconds. Rarely, it's more than a minute. And these patients are not going to have any focal neurological deficits. What about seizures? So the three key things that I want you to remember is, number one, from a physical exam standpoint, these patients can have postictal lethargy. That can last anywhere from minutes to hours. They may also have possible focal neurological signs. And the key thing here is that that can be either because of an underlying lesion that they have, or it can be because they may have Todd's paralysis, which can be common after seizures. The other thing to also consider is that this is a stroke mimic. You can potentially see this in strokes as well, so please keep that on your differentials as well. And then you also want to look for injury markers like we talked about, so specifically tongue laceration or bruising. What about psychogenic non-epileptic spells? The three things that I want you to remember are, number one, inconsistent movements. You're thinking about the motor is not really following that typical seizure pattern. They may have side-to-side shaking, or they may have their eyes very harshly clenched. There's really going to be no true postictal state in these patients. And these patients may also be distractible during the event. Specifically, that might mean they're talking to you during the event, or they're responding to some kind of external stimuli while this event is occurring. What about red flags? So let's talk about some of them. Number one, family history of sudden cardiac death. If a patient tells me that multiple family members in the family have died at a young age, I start to consider some of these disorders, specifically long QT, Brugada, cardiomyopathy. Brugada, interestingly, is autosomally dominant inherited. So if multiple male members have been passing in the family, I start to consider this on my differential, and I try to investigate that EKG a little bit more. If patients tell you that they had a sudden onset no prodrome, I get a little bit more concerned. If they had a prolonged period of unconsciousness, now I'm starting to think about either seizure, some kind of CNS event, or psychogenic non-epileptic spells. And then if patients are having recurrent episodes without typical triggers, I get a little bit more concerned as well. So how can we diagnose our patients? What tools do we have at our disposal? So some of the key ones that we're going to talk about are EKG, potentially imaging, potentially labs, as well as ED monitoring. So EKGs, and this is definitely going to be one of my key takeaways for this. Don't compromise on this. Every patient that presents with syncope, you should get an EKG. I like this mnemonic a lot. It's called the ABCDE left-right rule. And I think this can really help to keep in mind some of the differentials when it comes to investigating EKGs to help rule out some life-threatening emergencies that can cause our patients to syncopize. So the idea here is that each letter refers to a particular condition. So when we're talking about A, we're talking about AV block. Mobitz type 2 and type 3 heart block are the big concerning ones. B, we're talking about Brugada syndrome, which is that sodium channelopathy that can lead to sudden cardiac death when these patients can go into ventricular dysarrhythmias. C, we're talking about QTC prolongation, which can lead to torsades. D, we're talking about delta wave, which is one of the findings that we can see in Wolff-Parkinson-White syndrome. And again, there's three findings: delta wave, short PR, and then wide QRS. E stands for epsilon wave, which we can see in arrhythmogenic right ventricular dysplasia, which is where you get fibrofatty tissue that gets deposited in the right ventricle of these patients, and that can predispose them to arrhythmias. L stands for left ventricular hypertrophy. So if we hear a new murmur or we're seeing signs of left ventricular hypertrophy on an EKG, maybe we consider aortic stenosis or hypertrophic obstructive cardiomyopathy on our differentials. R stands for right ventricular strain, and that's, again, we're thinking about PE on our differential. In terms of labs and imaging, we're going to be checking electrolytes, we're going to be checking glucose, CBC, and we may consider getting a troponin if we're suspecting ACS or some kind of cardiac event that led to the patient's syncopal episode. In terms of imaging, we've got CT and MRI imaging at our disposal. The one key point here that I would stress is that CT is generally low yield in syncope, but I would consider it if your patient has any focal neurological deficits, they have new onset confusion, or you're getting concerned for some kind of stroke or underlying structural lesion. It may also help if your patient syncopized and then suffered head trauma from the actual event, and that's where, again, it does have some utility there as well. Now, in terms of our monitoring, a lot of these patients are going to end up on short-term telemetry in our emergency department. We may get lucky and we may detect brief arrhythmias or bradycardia. Patients that we're suspecting either have a cardiac cause or a seizure are going to typically be admitted for extended monitoring so we can get to the bottom of what happened. And then the patients that have a normal EKG, benign exam, and no red flag signs whatsoever, those are the patients that are typically going to get discharged. One of the questions that I get frequently asked from my learners are, do we have any other special tests at our disposal that we can educate our patients on so that they can get a more working diagnosis, especially if the diagnosis is in question? Yeah, we definitely do. So let's start with talking about one of them, which is tilt table testing. And the idea here is that this is a diagnostic procedure that's done to diagnose neurogenic syncope. The patient's basically strapped to a table at around a 60 to 80 degree angle, and we're trying to see if we can provoke some of these symptoms. And this is typically done when our workup is inconclusive, but we think that the patient has neurogenic syncope. And the idea here is we're trying to confirm that diagnosis by seeing if we can reproduce some of those symptoms, including hypotension and bradycardia. We'd want to avoid this in patients that have any instability in terms of their hemodynamics. So specifically somebody that has severe orthostatic hypotension, you want to definitely avoid this. Somebody that has severe aortic stenosis, you definitely want to avoid this as well. Another special test that we can consider on an outpatient basis is an EEG, and referring these patients to neurology for that. And the idea is we would do this when the clinical presentation is unclear, but we're thinking about seizure on our differential. Another time where I would consider this is if a patient has recurrent episodes, but they have a negative cardiac workup. The key point that I would stress here is that a normal EEG does not fully exclude epilepsy, but epileptiform activity does support that diagnosis. These patients may also benefit from a Holter monitor. And the idea here is that this is essentially a continuous or intermittent EKG that's done over days to weeks. The way I explain it to patients is that, hey, the EKG that we did in the emergency department, that's just a snapshot in time. This Holter monitor is basically multiple pictures over a period of days to weeks that can really help us narrow this down. And I'm typically doing this if I'm suspecting some kind of arrhythmia that's contributing to my patient's symptomology. We may also consider echocardiogram imaging. And the idea here is that if we hear a murmur on exam and or our patient is presenting with heart failure signs or symptoms, or there's a family history of cardiomyopathy, then I would consider getting an echocardiogram to further diagnose this patient. The idea here is that, again, the echocardiogram is going to help us identify any valvular lesions, ventricular dysfunction, or like in this echocardiogram that you can see on your screen, hypertrophic obstructive cardiomyopathy. And here you're seeing a parasternal long axis as well as a parasternal short axis view, which shows you a thickened myometrium, which would make me very suspicious for hypertrophic obstructive cardiomyopathy. What about physical exam? So from a physical exam standpoint, you definitely want to really screen those vital signs very thoroughly. Try to see if you can pick up on any orthostatic vital signs which may be contributing to your patient's symptoms. You want to check for tongue lacerations and any signs of trauma. And from a neuroexam standpoint, this is where you really have to be thorough. Check for any cranial nerve deficits, check for any motor deficits. And on a cardiac exam, I'm checking to see if they have a murmur because that'll get me suspicious for some kind of structural lesion as well. And make sure that their rhythm is normal and they don't have any signs of heart block because that can also cause syncope as well. Now, what about high-risk features? So the patients that are going to be high risk are going to be above the age of 60. They have known heart disease, they have an abnormal EKG on presentation, and or they have persistent abnormal vital signs. Now, this is where I think our clinical decision tools can really help us. One of the more popular ones is the Canadian syncope rule. And the idea here is that if our patients do not miss, if they do not have any of these high-risk criteria, their risk of having any kind of significant cardiac event in the next 30 days is very low. And that's around 0.3% if they're very low risk and 0.7 if they're just at low risk. So I tend to use this the most. This has been studied, well validated, and I think it's a great clinical tool that's out there. There's also the San Francisco syncope rule. And again, this has also been studied in some of the future studies that have been done on this. It hasn't had the same high sensitivity that it did in the original study. But again, this is out there where if they meet one of these clinical findings like congestive heart failure, decreased hematocrit, abnormal EKG, shortness of breath symptoms at the time of your evaluation, or a systolic blood pressure of less than 90 on triage, if they have any of these high-risk features, that patient is considered high risk and definitely should warrant further investigation. And there's also the Rose rule as well that's out there. Now, we've talked about different clinical decision tools. One of the questions that I frequently get from my learners is, hey, what's the best? And to be honest with you, we're not 100% sure. I personally like the Canadian syncope rule the best, but there was a study that tried to answer this question, and it's one of the few studies that compared multiple different clinical decision tools. This was actually done in China in a single center, and this was a retrospective observational cohort study. They looked at patients that were aged 60 years or higher that presented with syncope, and they applied these clinical decision rules to help assess for any kind of significant adverse outcome that could occur to these patients within 1 month of presentation. The sensitivities were all relatively the same. Some scores performed a little bit better. The Boston score performed the best. I'll be honest, I don't personally use the Boston score because it's very hard to apply. It has over 25 different variables. So from a clinical standpoint, that's hard to apply in real time, especially in a busy emergency department shift. But all these scores did have high negative predictive values. So for me, your clinical gestalt plus one of these clinical decision tools can really help narrow down and help rule out some of these life-threatening things and help with your dispositions as well. So when we talk about the clinical pathways in the ED, there's really three things that are going to end up happening. Patients that have high-risk features are going to get admitted. They may need telemetry admission. They may benefit from an echocardiogram or EP studies if you're suspecting arrhythmia. And then if they have focal neurological deficits, you're probably going to want to get your neurology team on board as well. Patients that have an unclear etiology that are safe for discharge, we may consider outpatient testing like till table testing, EEGs, and while they're in the emergency department, we may get labs and imaging as indicated to further evaluate for what's happening to them. And then patients that are low risk, that have a normal EKG, reassuring exam, we can consider discharge with close follow-up. So what about discharge instructions? I tell patients, hey, let's try to avoid triggers as best as we can. And this is where your history is going to be very important. If you're suspecting that their syncopal event was due to dehydration, you want to tell them, hey, let's try to maintain appropriate hydration and salt intake, again, assuming there's no contraindication. And if I'm suspecting that they may have some kind of neurogenic syncope, then I may refer them for outpatient tilt table testing. The patients that have high-risk features, those are the patients that are going to have an abnormal EKG. They have structural heart disease or CHF signs. If they have recurrent unexplained episodes, or I'm suspecting some kind of new seizure, and or they suffered a significant injury from their syncopal event, these are the patients that I'm admitting to the hospital for further workup. Let's talk about some special populations: pregnant patients, older adults, and children and adolescents. So when we talk about pregnancy, we have to talk about some of the physiological changes that are happening during pregnancy that can actually increase the risk of our pregnant patients having vasovagal episodes. Specifically, the two big ones are, number one, these folks can get venous pooling, and they also have a much lower threshold for hypotension because they can get anemia that can develop during pregnancy. I would also consider eclampsia on my differential if I have a pregnant patient that has a seizure and hypertension and proteins in the urine that ends up having a syncopal episode. And I would also consider HELP syndrome if I have a pregnant patient that's endorsing a severe headache with visual changes in right upper quadrant pain and then has a syncopal episode. So you definitely want to keep those two differentials on your diagnostic differentials because they can be very helpful to consider. Now, syncope in older adults is definitely going to be more challenging. And the reason why is these older patients are going to have multiple comorbidities. They're going to be at risk for polypharmacy because they're going to be on multiple different medications like diuretics, like sedatives, like antihypertensives. And because of that, they're going to be at a higher risk of orthostatic hypotension. We also worry about cardiac concerns because they may already have structural heart disease as well, and that may contribute to their syncopal event. So I would stress, try to review their medication lists very, very thoroughly because you want to see if there's any culprits that could have triggered their syncopal event. Things like increases in doses, specifically antihypertensives and diuretics. Check those orthostatic vital signs because that's going to be the key in older or volume-depleted patients. These patients, I would have a low threshold to get cardiac testing, things like putting them on telemetry or getting an EKG. And then I would also consider CT imaging, especially if I suspect there may have been some trauma, or if they have an abnormal neuro exam, or if the cause is really unclear. And the key thing is just be judicious with your fluids and your blood pressure management because you want to try to avoid over-diuresing these patients and also aggressively lowering their blood pressure. What about the pediatric patients in our adolescent populations? Generally speaking, the most common cause is going to be neurogenic or vasovagal, so really that history is going to be important and try to identify those triggers. Some of the more common triggers include school vaccinations, needles or exposure to needles, dehydration is another big one, and then emotional stress, and some kids can also skip meals and then end up getting hypoglycemic, leading to syncopal episodes. Typically, it's going to be benign as long as you're not seeing any kind of abnormal cardiac signs or family history. What are the red flag signs that I would watch out for? If your patient has any family history of sudden death, I would start to consider some of these on your differential, including long QT syndrome, Brugada, and hypertrophic obstructive cardiomyopathy. If they're having exercise-induced fainting episodes, that's when my suspicion for structural heart disease gets more enhanced specifically. So now I'm thinking about things like hypertrophic obstructive cardiomyopathy or something else along those lines, and I would definitely make sure that these kids have good follow-up, especially if they're well appearing on your initial presentation. If they're having recurrent episodes without typical vasovagal symptoms, that's another red flag that I would consider for further workup. Don't compromise on your EKG because that's going to help you assess for things like long QT syndrome, HOCM, Brugada, some other channelopathies, and have a frank discussion about hydration and making sure that these kids aren't skipping meals, they're eating and drinking right. Generally, a lot of this is going to be reassurance, especially if their history is benign, they have rapid recovery, and you've identified a typical trigger, and these kids can just have safe discharge with close follow-up. The kids that I'm suspecting that have had some kind of arrhythmic event or they have some kind of congenital anomaly, I definitely want to make sure that they're getting set up to get an outpatient echocardiogram or Holter monitor or potential stress test. So what are the key takeaways? Number one, always get an EKG. This is non-negotiable. This is going to really help you narrow down some of your differentials. You want to get a thorough history. That's going to help you differentiate between syncope versus seizure versus psychogenic non-epileptic spells. And this means identifying triggers, asking about medications, asking about prodromal events, asking about what happened after the event. And then really don't forget about those red flag signs. Thank you so much for joining me for this talk.